And sometimes we may be thinking that we're speaking the same language, but we may not be. So Muslim participation in bioethics, what are the benefits? Well, as Muslims, certainly we have an emotional attachment to the ideals of Islam. We feel that Islam has something to offer to this entire discourse, and because of that, we certainly emotionally feel driven to participate. I think at a deeper level, we do have a belief in the principles of Islam, and we want those principles to come forward into this discourse. As a physician, we bring to the table the ability to frame questions, and probably even more importantly, to provide specific context. And sometimes this is part of the frustration of the physicians, is they don't believe that the questions being answered, I think, as you brought up, were actually framed correctly in terms of the rulings that are given back on the other side. But what are the risks? And I separate these in terms of Muslim and physician, not that we're all completely dichotomous, but it is a reasonable question to ask what part of us as Muslims and physicians are actually driven by the fact that we're physicians versus the part that's driven by the fact that we're Muslim. So as far as being a Muslim, I say that most of us, myself certainly included, suffer from insufficient knowledge. And often that insufficient knowledge with respect to understanding how an actual Islamic decision is come to, that lack of knowledge actually can lead us to misinterpret things. And I'll give you an example of how that might happen. I think also as a Muslim physician, sometimes we come to the table with an agenda. And that is that we, for example, what if we are a transplant surgeon? And we come to the table, ask a question about whether transplant surgery is okay or not. I think in an academic discourse or in a very sincere, honest way, we have to be careful that we leave our agenda at the door when we enter into this discourse. And I'm not sure we as physicians are always able to do that. As physicians, sometimes, and I was very impressed, and again, I didn't talk to Shireen before her talk, but this idea of the scale of the issue. The questions that seem to us to be incredibly important because we're faced with them every day may not in reality be that important. And we sort of do have sort of this self-imposed aggrandizement of ourselves, I think sometimes, that the questions that we come up with are particularly important. And the other problem is that answers, certainly as physicians, sometimes are driven by context instead of evidence. How many of us haven't maybe given a decision on a medical issue that's primarily driven by context but not by evidence? And we see that in healthcare practice all the time, that we're really driven by context. And again, as a Muslim physician, we have to be cautious that that doesn't become such a habit that we lose our ability to be objective, to actually step back for a moment and consider the idea that maybe the evidence leads us to an answer that we didn't come to the table with. And that's not easy to do. So what are the major risks for the Muslim physician when you go down this road? And I'd say they really come down, and again, trying to figure this out into 15 minutes, I had to pick 3 or 4, and these are 4 that really came to the forefront of my mind. The first risk is the definition of life. If you look on your pamphlet for this conversation, and we'll come through a slide that describes this, there's a distinct definition that we're using of life in the context of even this conference. That may or may not be the Islamic definition of what we consider to be life. And I'll go through what I mean by that. Another major risk is that there's differences in what we mean when we say the word evidence. What does evidence mean in an Islamic context? What does evidence mean in a medical context? The fact that we're so context-focused, we are context-driven by asking a question, and we're certainly context-driven in deriving that answer. And then what I call a fatwa-based assessment of what councils have actually come up with, or what jurists have actually come up with. That we sort of stop at the level of the fatwa, and I think we got a sample this morning of what might come into play. And again, putting my pharma hat, the analogy for me is that is trying to judge things based on what I call off-label use. Exceptions rather than the ultimate rule. So you can imagine this may be what the round table looks like tomorrow. And the problem is, sometimes in these conferences or in these discussions, we don't actually talk about the elephant in the room. And I think there's several elephants here that we should actually be explicit about. I'm not going to point out who's who at this table, but it looks like it could be here at Michigan. Let's think about the definition of the word life for a moment. So in medicine, we are really driven, and in all of our education as physicians, Muslim physician or non-Muslim physician, all of our education is really driven to understand life is really encompassing one distinct phase. Maybe we have some insight into before birth, and then we talk about life in this world. In Islamic ethics, life is defined in 3 distinct phases. You have a phase before you come to this world, a phase in this world, and you have a life in the afterlife. This fact that as a Muslim you have to incorporate this construct of life in an afterlife is a critical piece for the Muslim physician to consider. So even when we contextualize a question and we don't get an answer that we expect, this critical piece, sometimes we, for some reason, forget this. That maybe the reason we're getting something isn't it doesn't always look easy for the life of this world, but it is because there's a benefit in the life hereafter, or there's a risk. Conversely, that there's a risk in the life hereafter. Again, something for us to balance and to think about. What is the standard that we usually use when we think about life? Well, we talk about improving quality of life and extending the length of life. Well, that makes sense for a physician. We want to improve the quality of someone's life. We want to treat comorbid conditions. We want someone to be healthier, to be happier, all of these things. And then we also want to extend the length of the life. As a society, we take great pride when the life expectancy of the society goes up. We show that as a sign that our healthcare system is actually doing something productive. Well, in Islamic ethics, you may use the same constructs. You may say we also want to improve quality of life. But that life that's being used there has to encompass all three phases. It cannot be exclusive, and it cannot be to the exclusion of improving life in the afterlife. Because if you do, maybe you're not actually improving the quality of somebody's life. And that's certainly something that we should, as Muslim physicians, pause and think about from time to time. Then when we think about the issue of end-of-life care, and this is where I refer to our pamphlet, on the title of that we say it's end-of-life care. Well, for the Muslim ethicist and the Islamic ethicist, what we're really talking about on that pamphlet is end of this life in this world care. No one's presuming that at the end of this life, for the Muslim ethicist, that life is over. So what you're really doing, and it's funny that even on the pamphlet for an Islamic bioethics conference, we use the term end of life, because in a medical context, that's what we are to understand. And again, I'm not trying to nitpick, I'm just trying to raise these issues in your minds to say that, these are considerations for the Muslim physician if they really want to go down this road to engage in this discourse. How do we think about evidence? Now, this is my favorite topic, right? In medicine, we look at case series, we look at observational studies, we look at randomized control trials. We have distinct methods that we use for weighing evidence. Well, evidence in Islamic ethics, depending on which point of view you come from, but to a large extent, to summarize, it really comes down to evidence is primarily revelation. And revelation either through the Quran and Sunnah, and again, I don't have the qualification to go into the details of that, but the idea that evidence there refers to revelation versus what we're used to thinking about as evidence, again, it's a moment of pause for the Muslim physician. How qualified am I as a Muslim physician through my medical training and perhaps my Sunday school training in Islam to really understand revelation? How much of my life have I spent studying revelation to appreciate it, to understand it, to be able to derive principles, derive hukam, and so on? Again, distinguishing that expertise in our minds is important. Applying the methods for weighting evidence, we still have that same idea in Islamic ethics. There are methods by which we weigh evidence, but those methods may not be the way that we do. We may give great weight to a randomized control trial that's done, because we're familiar with that. We know how to weigh evidence. In the other world, in that world of Islamic ethics, we may not have a great sense of how to weigh evidence. So on the surface of it, it may look to us that there's no justification for this ruling. It doesn't make sense because the weight of the evidence doesn't make sense in our construct, through our lens. Is there consistency? That's what we look for in medical evidence. Is there consistency across different types of trials? Do we see it across different populations? Well, and then we also talk about this idea of causality, that there's a certain threshold that we cross in medical knowledge that then we attribute something to something else. In basic epidemiology, right, we have these basic criteria that we go through. Is something causally related? Well, there's a certain amount of evidence that you have to cross before you get to that line. In Islamic ethics, it may take time for us to get used to this idea, but to some extent, evidence is a little bit more static. It's not necessarily moving all the time. And again, I'll try to expound on why I think the evidence is a little bit more static than it is certainly compared to medicine. The idea that evidence evolves and that over time we actually get closer to the truth, that's something that we buy as physicians. We think that as time goes by, we know more. As Muslim physicians, again, we ought to pause and say, as Muslims, do we actually believe that? Do we actually think that as time goes by that we're closer to the truth, or are we further from the truth? And I'll leave that question for you to hopefully ponder about. But I'm not convinced necessarily that as a Muslim, we definitely would always buy the argument that as time passes, that we as human beings get closer to the truth. One may actually argue that sometimes we get further from it. And again, in Islamic ethics, we have this idea that context evolves, and there's no doubt about that. that requires application of evidence, but that evidence in and of itself may not have changed. And then you apply that evidence to a new circumstance. In the use of context, in medicine, we use context to generate a question, we use it to frame a question, we use it to determine the answer, and then we use it to apply the answer. Patient comes in front of us, we take a history, we make an assessment, and then we determine what to treat them with. All of that process is very contextual. If we're a really good physician, we may actually incorporate some evidence, if we happen to have read a study maybe a week ago. But in general, this is exceedingly contextual. And study after study will show this, that in general, physicians will practice the way that they practiced at the time they graduate from their residency. It's very difficult to educate somebody later on in life. I'm hoping that's not always the case, but in Islamic ethics, you may generate the question based on context. We as a physician may go to an Islamic scholar and say, we've generated a question based on the context. We may frame that question, but the answer itself, there is a step where that mufti or that scholar will go off, maybe into a dark room, maybe go away for 2 weeks, and ponder about that question. Go through their books, think about the evidence. That process, that pause, that process is independent of the context that I drove the question from. They may come back with that answer, and then they may apply that answer in a fatwa. Then again, they may incorporate the context. But there is this one step that is independent of context. And again, I think that's important for the Muslim physician to appreciate, that when a scholar doesn't give you an answer immediately to a question, maybe they also need a little bit of time to ponder on it. Maybe they need to go back to their evidence. They need to think about it. But again, they need to do that independent of a context. Fatwa-based review, 1 or 2? 1. Oh, goodness. Okay. In very simple terms, if you were, as a physician, to decide whether a drug has efficacy or safety based on off-label use, so physicians are using a drug in a certain way and you study that pattern, and from that you derive your idea that this drug works for ABC, then again, you may be able to provide some useful information, but the fundamental flaw in your thinking is that you've been misled with regard to establishing a best practice. If you're going to establish a policy of what that drug is best for, you best better go with the label, because that's actually where the best studies were done. That's why that drug is labeled for that. The analogous thing happens to the Muslim physician when they only study fatwa. If you look at a fatwa-based review based on individual cases, we don't always appreciate that those particular rulings were based on a contextualization of a particular hukum, of a particular answer. And if we don't go back to appreciate what that hukum is, we may actually base policy on an off-label use without really understanding what the hukum was. And that's really the risk. So what would that look like? Well, let's take the example of organ transplant. Let's say, for example, that there's a fatwa allowed, but that fatwa that was allowed was an exception for a secondary consideration, and it's not really reflective of the whole evidence that really is based on and that fatwa doesn't tell you that this was only based on a secondary consideration. But the primary evidence in that fatwa actually raises some doubt. So it's been contextualized for a particular circumstance, we're going to allow it. Now, if you decide, and if you only study that fatwa, you may surmise that it is allowed, and then this is the dangerous part. And not only is it allowed, but that it reflects the totality of the evidence, and that is a false assumption. And then based on that false assumption, you may actually lead to the impression that now an obligation actually exists. That not only is organ transplant okay, but because it's okay, it's also obligatory. So you've created an obligation that never really existed. And that also is a horrendous thing to do. So again, a caution to the Muslim physician who's going to dabble in Islamic bioethics. Definitions of benefit and risk, I won't spend a lot of time on this, but the bottom line is, the key thing I wanted to bring out here is that when we talk about risk in a medical sense, we have a pretty good idea of what we're talking about. We may use the word harm or whatever it is. In Islamic ethics, we're talking about sin. That may be the terminology that's used. So if someone is talking about the word sin, how do you bring that into a common or a secular discussion? That is a big challenge for the Muslim physician to incorporate. What does it mean when someone tells you that something is sinful? How do you interpret that? And how do you bring that into play? But certainly that has to be a consideration if you're going to try to sit at this table. So what is the overall benefit risk? I think there are definitely benefits to the Muslim physician being part of this. One benefit is you get to come speak at conferences like this. I do think there is some weight that should be given in the fact that as a Muslim physician we have an emotional attachment to a psalm. I don't think that should be underrated. I'm not meaning that in a pejorative way. I'm actually saying that's a good thing. And I think that as a physician, we do have the ability to frame questions and provide context. But what we don't have the ability to do, and I think we need to be perfectly honest about this, is we don't necessarily have the qualifications to define life. We don't necessarily appreciate the subtleties and differences in evidence. We are exceedingly context-focused as physicians, and that may be a hazard in this sort of conversation. And we tend to base our assessments on fatwa and off-label use, and I think sometimes we make some fundamental mistakes in our thinking. And I think we also have a risk in the actual definitions of what we understand to be a risk here. What are some other roles for Muslim physicians? I'm not trying to make the argument that we shouldn't be at the table or we shouldn't have a participatory role, but I do think we, as Muslim physicians, need to think a little bit more broadly about what is our role in the overall ethical discourse. One is in the ethics of professionalism. What do we as Muslim physicians understand about what it means to be a professional? Have we as Muslim professionals, we have thousands of Muslim physicians, is the practice of medicine in America different because Muslims practice it here? And if the answer is no, then we probably have some work to do. A patient advocacy focus. Is there a larger ethical issue? That the fact that some of our patients can't actually pay for the care that we want to provide, is that a more important ethical issue for us to spend our time dealing with than a one-off or two-off contextualization of a problem that may not nearly be as broad? Maybe that's where our focus should be. The chance to learn, and this is a huge emphasis for me, is that as Muslim physicians, we shouldn't see this as someone telling us that we don't know anything. Again, my intent is to encourage us to learn more. And I think that's where the fun is. I think that's where the excitement is for us to engage in learning about these things in a lot more detail than perhaps we've done in the past. And lastly, I think a role for us is to serve in partnerships with our Islamic scholars. Not in opposition to them, but in partnership with them. They need us to be able to say things honestly, but not necessarily come to the table with an agenda. And vice versa, we need them to meet us at the table so that we can hopefully come to good decisions. Thank you. Sorry.
All right, thank you, Dr. Arzullah, for those moments of pause and keeping Muslim physicians humble. We'll push through with Dr. Farkurlan. Fortunately, those of us who work on clinical ethics are very familiar with his work. He is Associate Professor of Medicine and Co-Director of the Program of Medicine and Religion at the University of Chicago, and he's done extensive work in this field. For the interest of time, I'm going to... I'm sorry? No slides. Oh, no slides. Okay, great. Okay, so...
Well, it's... I had the privilege of going to a lot of conferences in my work, and I have to say this has been the most interesting conference so far that I've been to in a long time. I think part of what's so refreshing to me is the tenor of the conference shows that those both speaking and in attendance are serious about trying to understand how we ought to live, how we ought to practice. There's not just an exercise in a sort of academic play on different concepts. And I'm going to improvise my talk. I'll stick to my few minutes, but improvise because so much has been said this morning that has been said well that I can reduce my comments a bit and comment on some of those things that have been said. And I'm going to start with Professor Brody's talk, which was a terrific, I think a terrific introduction. And in it, he talked about both the power and some of the critiques of the Rawlsian framework for thinking about how we enter into public conversation with each other in a plural world, a morally plural world, to discern how we should order our common life together. And it strikes me that to me, the weakness that's most palpable in my sense of the Rawlsian framework is the construct of the personal and the professional, or the public and the private. The public and the private, I guess, is the more primary, as two clearly distinguishable spheres. As Professor Brody noted, the boundaries between these spheres are always contested, as are between the religious and the secular. But it seems to me the contesting of the boundary between the public and the private, or with respect to medicine, the personal and the professional, is really important. What we haven't really heard this morning is a lot of conversation about, well, this is my private view, but of course over here I'm a professional and I keep those separate. That's not been a part of the conversation. I find that refreshing, and I'll describe why in a moment. I'm talking about what religion has to do with the practice of medicine. There's been quite a bit of attention in the United States to what religion has to do with patients' health, both as a factor, a sociological health related factor that may impact outcomes, but as well to how patients experience illness. But yet even in the cultural competency literature, which is one of the literatures in medicine, physicians are often portrayed, in contrast to the very unique and interesting and diverse patients, physicians are portrayed as sort of generic representatives of biomedical science, of a medical profession. And it seems to me that, as we've seen some this morning, that doesn't really do justice to the reality that physicians themselves come to medicine with all their own particularity. And being Muslim or having a serious commitment to Islam obviously would be one of those interesting, unique sort of aspects. And I'm going to consider what religion has to do with medicine by comparing and contrasting to what science has to do with medicine, because science, I think, it seems more obvious in our culture that science has a lot to do with medicine. Now, no one ever asks what science has to do with medicine, any more than they would ask what books have to do with learning or what tools have to do with carpentry. Science is what makes medicine work. As a result of modern science, people in developed nations now live twice as long as they did 100 years ago, and they live with much less disability. Yet for all the contributions of science to medicine, clinicians must look elsewhere to find their motivation and direction. In a way, medicine would never get off the ground without functionally religious ideas, because medicine requires a motivation to care for the sick. Science has provided vast knowledge about how we might care for the sick, but science is silent about why we ought to care for the sick. And as we've heard this morning, religions are not. It's not incidental that the concept of a hospital began when monastic communities enfolded the care of the sick into their lives of liturgy and prayer. Religions often ground the care of the sick in sacred and transcendent obligations to God and neighbor. And that's not to say that those who think of themselves as irreligious lack the motivation to practice medicine. Our common experience proves otherwise. But it is to say that clinicians need to draw on some sort of functionally religious idea to at least be able to make sense, to explain why caring for the sick is a good and worthy activity. Sheikh Musa this morning talked about teachings that animate for Muslim physicians the practice of medicine, a commitment to preserve life and to preserve the body, to ward off harms, the preservation of health, and so on. Those are not just adopted from a general secular framework, although that is an area of a lot of agreement among religious traditions and secular traditions. But those are explicitly part of the teaching of Islam. Clinicians derive their motivation to care for the sick from a variety of sources, but it doesn't come from science. Science is just neutral regarding that. Indeed, the practice of medicine is a bit of a puzzle for the overarching framework through which so many scientists make sense of human behavior, namely Darwinian evolutionary theory, and specifically evolutionary psychology. There could hardly be a practice less conducive to the reproductive fitness of a population than spending enormous resources caring for the sick, the deformed, the weak, the aged, those who either have no capacity to contribute to the gene pool because they're infertile, or whose contributions to that pool will reduce population fitness. So natural selection and the physician appear to be at cross purposes. One works to eliminate the sickly, the other to save them from elimination.